Hi, none of the individuals in a position to control the content of this activity, including the speaker, planners, course director, or reviewer, have any relevant financial relationships. The objectives for this training today, number one, is to review the need for physicians to have professional development related to mental health. Two, to explore the top mental issues that physicians and medical professionals tend to diagnose. Three, reflect upon physicians' own personal mental health and why speaking to a professional is really part of their own Hippocratic Oath. And number four, to evaluate three specific strategies to reduce mental health stigma. Hi, I'm Dr. Steve Bain. I'm a licensed professional counselor supervisor and a national board certified counselor, and I work at Texas A&M University, Kingsville as a professor and as the director for our Institute for Rural Mental Health Initiatives. I really am honored to be able to bring this presentation to you, the medical professionals who'll be watching this. I have for a long time advocated the need for medical professionals and mental health professionals to work closely and in tandem as they deliver services and help those in our community who struggle with issues related to emotional, psychological, or mental illnesses, or just the regular run-of-the-day mental health challenges that we all face. And so I am very honored today to be working with you in Healthy South Texas to present this presentation. And so today what I really want to do is just remind us of the fact that we're talking about medical well-being and mental health. Often we see, we try to differentiate between mental health and physical health. But the truth is they're the wings of the same bird. They are connected together in such a way that you can't really have one without the other. So if I think about physicians and the important role they play in mental health treatment, as particularly in rural areas, I think about my own experience. I was born and raised in a little town called Savannah, Tennessee, several decades ago. And I remember as a young child just dealing with family issues and being very anxious. No one knew really what it was at the time, but to have a little bit of attention deficit disorder, hyperactivity disorder. And so my mom took me to the doctor at about 8 or 9 years of age. Had a lot of anxiety, just very nervous, fidgety, and having difficulty in school somewhat. And we had no idea what a counselor was. There were no counselors. There were no psychologists. There were no psychiatrists available. It was just our doctor, our family doctor. And I could remember sitting with him and just listening to him talk to me and how that made me feel better, knowing that someone as revered as a medical doctor, our family doctor, was talking to me about the issues that I was facing. So as I got older, I recognized the fact that in many communities, the number one person to hear about any mental health issues or emotional issues of clients is the family practitioner or the general practitioner in the area. This is particularly true of those who live in rural and remote areas. And I did live in a rural and remote area in this little town of Savannah, Tennessee. So what I want to do today is I want to talk about this unique relationship and connection between medical well-being and mental health. And so, first of all, let me start with some fast facts about treating mental health in the medical profession. And it's taught at an early stage in the professional training of medical professionals that compassionate health care, including mental health treatment, is linked with better client satisfaction, treatment adherence, and clinical outcomes. We know when clients feel like they've been heard, when they feel like that their Emotions have also been given a priority. They tend to do better. They tend to respond better to not only the medicine that's been prescribed and the treatment that's been prescribed, but they also tend to stick with it and follow the doctor's advice because they trust the doctor. They believe the doctor understands them and hears what they're saying. And of course, the clinical outcomes, the hard data shows us that those who feel like that they have been heard, that they feel connected, not only at a physical level but an emotional level, they tend to have a better outcome and a better prognosis for recovery from whatever it is that they're facing. The fact of the matter is that in the United States, 1 in 6 patients take a psychotropic medication. In many cases, they are prescribed, as we said earlier, by family practitioners, general practitioners. So it's not like they've gone to a psychiatrist or to a psychologist and got the treatment, particularly in the rural areas. They're depending upon that doctor, that family practitioner, that community doctor to provide what they need. This puts a tremendous amount of pressure on the rural or remote doctor. Even in areas in Texas, it's not really remote. People still tend to depend upon the family practitioner for any types of medication or prescriptions related to psychotropic medication. Most psychotropic medication in the U.S. is prescribed by non-psychiatric physicians. Now, as we said, this puts a tremendous burden on the physician, which means that it's very difficult to provide follow-up. It's difficult to provide counseling connections after that because the fact of the matter, there are not that many mental health professionals in that area, especially in rural areas. And I'll share more with you about that a little bit later on when we talk about the shortages in what we call health provider shortage areas. Another fast fact is that most people with poor mental health will be diagnosed and treated in the primary care setting, which means this type of training and other elements of training are so critical to helping the medical professional, whether it's the family practitioner, general practitioner, nurse practitioner, RNs, whomever it may be, any medical professional. That's why this type of training is so very important. We also know that mental illness also complicates other medical conditions, making them more challenging and more expensive to manage. It's very difficult to work with people who are who have presenting health problems, physical health problems, when they're also having simultaneously and in conjunction with mental and emotional issues as well. So mental illness does complicate other medical conditions. So I want to talk a little bit today about understanding the need for mental health training for physicians. Often, the focus of medical health excludes and overrides the mental health of patients. It's not been that many years ago before there was a rift, there was a obvious division between medical and mental health. One of the great things that we have going for us at the university is that we have some international connections. And one of the great ones that we have is with a university in Scotland where they talk about remote and rural. And we look at the various things that are happening in their world on an international level. And I can tell you that not only here in the United States, but internationally, often the focus on just the medical part, just the medical issue, often overrides the mental health of patients. We see that when doctors are so swamped with the work that they have and the patients and the clientele, that they usually don't have time, they don't have sometimes the expertise to listen to what's really going on. And that's one of the things that we'll be trying to cover today and understand it. I mentioned the international aspect of it earlier. Often in the UK and Scotland and places like this, it is seen, it's understood that the medical and the mental health of a patient go hand in hand. They don't differentiate between the two. And we've seen that a lot happen. We've seen that a lot, and it happens a lot here in America. And hopefully that will be one of our challenges, is to move to an attitude of and promote the ideology of this being one and the same person, not just a medical or physiological aspect of a person, but also the mental and emotional part of this individual. Another thing that we need to understand when we talk about mental health training for physicians is that because of the overwhelming workload, many physicians rush the patient visit, and they don't really have time or take the time to listen to the mental health needs. One of the strong points of mental health counseling is being able to listen to, empathize, and hear what the client or what the patient is presenting. And sometimes we find that if physicians can just slow the momentum within that patient's visit, they find that there's more to this situation than just something physiological. There's something that is emotionally based, psychologically based, mentally based, that may be impacting this client's physical health. We also know that mental disorders are the most common health problem physicians face in practice. And this makes it a population problem. It's not just a problem that necessarily has to do with people in rural areas. It's not something that necessarily has to do with people in a certain culturally profound location. It has to do with the fact that it is a population problem, all of us, and each community is different. I know some of the research that I do for my rural mental health counseling and also my rural mental health research, one of the things that we really try to show is that each rural community is different. Each rural community has different challenges, and they see mental health. They see the correlation between mental health and physical health from a different perspective. So it's important, it's incumbent upon us not to say, well, this issue of mental health is just particularly true of this segment of the population or this location of the state or these rural areas. It really is a population problem where we all face issues. We think about the tragedies related to people like Robin Williams, and we knew of non-suicidal self-injury when it was first reported to us by Princess Diana. So it is not something that's just true of the common person, the average individual or the citizen. It's true of all of us. It's a population problem, and we need to understand it as that. We also know that the tremendous shortage of mental health professionals makes the PCP, primary care physician connection, vital. I can't repeat that enough, and I can't stress that enough. The tremendous shortage of mental health professionals. Let me give you an example of what I mean by that. So in 2014, when I first started doing this particular level of research, I discovered that in Texas, just in Texas, 2014, 207 out of the 254 counties were considered HPSA, or health provider shortage areas. And for this discussion here, I'm going to talk about mental health providers. So professional mental health providers, this was something that was common in 207 out of the 254 counties of Texas. You fast forward that to 2021, and all but 2 counties in Texas were considered health provider shortage areas, which meant for the population there was a shortage of mental health professionals, and that included everyone, psychiatrists, psychologists, social workers, licensed professional counselors, whomever was working with mental health, psychiatric nurses, all of those professionals, there was a tremendous shortage. So it's not like we have gotten progressively better and stronger in the work that we're doing, there's a huge need for more mental health professionals, and that then makes it incumbent upon the PCP visit to provide for the clients and provide for the community those initial triage, mental health triage situations. It is so important and so vital. So what are the top mental health issues that doctors face, that medical professionals tend to see? Well, according to Inspira Health 2023, they basically are three major ones: anxiety disorders, depression, and PTSD. Let's talk a little bit about anxiety disorders. Now, anxiety disorders are characterized by underlying feelings of extreme fear or worry. I don't think we as mental health professionals understood how serious the issues of anxiety. We knew there were a lot. We knew that it was very common. We didn't know how bad it was until after COVID. And I say after COVID, after the initial onset of COVID. When COVID came on, we began to see people having anxiety disorders unparalleled in the scope of our social experience, particularly in the United States. We had people who were worried, if I go out, if I don't wear a mask, what's going to happen? We had people who were from international origins, many of whom were Asian origin, who were afraid that people would blame them in some way for the COVID outbreak. We had anxiety at levels we'd never seen before, and anxiety affecting and impacting populations as never before. We saw it in the school districts. We saw it in higher education as well as public education. We saw it among the rich. We saw it among the poor. We saw it among every ethnicity and cultural group that is in our nation, in our world. Anxiety was powerful and profound, and technology, instead of really being a situation where it helped people, it actually caused people to be more anxious as time moved along. Now, in that condition of anxiety disorders, there's generalized anxiety disorder. Generalized anxiety disorder, basically, it's just I'm very anxious. I'm anxious about the day. I'm anxious about meeting with people. I'm anxious about going out. I'm anxious about what I'm seeing on television. I'm anxious about the war that we're watching in Ukraine or in Israel. And so it's just, I really can't put my finger on it, but I just know that I tend to have anxiety just trying to get through the day. There's panic disorder. Social anxiety, we're afraid to go out in public, afraid to be around people. And then other phobia-based anxieties. I'm afraid if I touch something, if I don't wash my hands a certain amount of times, I'm probably going to get infected with something. I'm afraid to be around groups of people. I don't know if there's going to be a shooting. The tragedies that we saw in Uvalde and other places, all that happening at about the same time that we were just beginning to get through that big wave with COVID. We saw these tragedies happen before us. So much anxiety. If there is a definition, this is from my perspective as a mental health professional and what I've seen in my 63 years of life, if I were to say what characterizes us as a society, I would say it's anxiety. We have a lot of people who are very anxious and very worried. The second thing that we see a lot, and doctors see a lot of, is depression. Now, depression affects over 17 million American adults every year. Now, depression, to really oversimplify it, comes in two flavors. There's episodic depression, which means that we get in a funk, or we get into a rut, or we get into a blue mood because of something that happened, a breakup with a significant other, something that happens at the job. We tend to get a little depressed. But then there's clinical depression that is brought on by lots of different other things. It can be things that are having to do with something that we've inherited, or something that depression has happened as a result of medications or abuse of medications. Now, in the past, people with depression were sometimes written off as simply being sad or in a rut. But now scientists understand that depressive episodes have much longer lasting effects than simply having a poor day. And let me just go back and say this. Even when we're talking about episodic depression, where we're looking at depression that happens from an episode or some trigger event that happens, even that level of depression can send shock waves to the brain and to the emotional unit of ourselves, and can be sometimes more serious than what we think. It depends on how intense that depressive episode really is. And of course, the third is PTSD, post-traumatic stress disorder, commonly known as PTSD. Affects so many of our population. In fact, it affects women at significantly higher rates than it does men. And PTSD is caused by being exposed to a trauma. It's a treatable condition, but PTSD is the result of being near death, or watching someone die, or experiencing something that believes that you could potentially be in harm's way at a higher than normal rate. I remember my father was born in 1919, and I remember my father as a young boy. I remember him having dreams at night, nightmares, because he was in World War II. He was in the United States Army, volunteered in 1940. He was sent back home at the end of March 1945. He had been through some of the most horrific fighting that the Rhineland had to offer during World War II. And I remember hearing him calling out orders and yelling for men to get down. Nobody knew what that was called. Then my two brothers, my oldest brothers, went to Vietnam, and they were both in the Marines. They came back with PTSD as well, as we all know most did, especially those involved in combat. Post-traumatic stress disorder, we just began to understand a little bit more, and finally PTSD was named for that and shown to be that in that Vietnam era and with those Vietnam era vets. In World War II and World War I, they simply called it shell shock. That was what post-traumatic stress disorder was. And then we began to understand that this disorder, PTSD, is something that happens not only to those who are involved in military engagement, but also for women who have survived a particularly traumatic, abusive relationship and are afraid to go to bed at night, or afraid to walk in their house without making sure that no one's behind the door because a partner that they had who was abusive sometimes tried to beat them to death. And so there was that PTSD. PTSD is found now among kids, especially those who have seen the tragic effect. And I will say this, I think sometimes PTSD is brought on by what kids watch on television, and the significant impact of the media on the mental health, particularly of our of our younger generation. So anxiety disorders, depression, and post-traumatic stress disorders are all, three of these are probably the most common mental health issues that doctors diagnose and that medical professionals have to treat. Now, I want to shift gears a little bit now and talk not only about what you see and how to deal with that, but I want to talk to you about your mental health. And a couple of things I want to say right off the bat is that I think, especially in the medical community, there has been a huge tendency to stigmatize mental health among medical professionals. Why would you have a mental health issue? You have a great education, you have a great income, you're working, you're helping this. So why should I? And I certainly don't want to lose my license. I don't want anyone questioning me. So therefore, I'm going to keep it to myself. Well, there's a price to pay for that, because according to an AAMA report, the depression rate among medical residents was 29%. Nearly 1/3 of the medical residents reported what we would call clinical depression, while the rate among non-physicians was 8%. So nearly 3.5 times more than non-physicians. We also know that physicians die by suicide at twice the rate of the general population. Now, in and of itself, that lets me know that we cannot ignore this anymore. The pressure that's on our medical profession, the pressure that's on our doctors, who are often overworked and understaffed, and in some cases very much underpaid, leads to a tendency to be depressed, which can be a major contributor to suicide. So the fact that physicians die by suicide at twice the rate of the general population is just a very strong reason why we need to talk about it today and not ignore it. We also know that physicians are hesitant about reporting mental health concerns due to stigma within the medical profession, whether it's from their own learning institutions, or whether it's from their medical boards, or from their licensure or certification entities. They're afraid of being able to report mental health concerns. We also know that burnout continues to be a challenge among physicians, particularly since COVID-19. We know physicians who talk to us about the challenges they face having to do with long hours, especially when they're in residency. But what we don't hear a lot about is the fact that the burnout that happens continues to be going on even after residency. The burnout, the changes, the legal challenges often, the lawsuits that are brought against physicians, the fact that we are such a litigious society brings a lot of stress upon physicians. And often they're like, you know what, it's like, I don't seem to be making any difference. I don't seem to be making any headway. I think I'm about to burn out. And so since COVID-19, we've seen the burnout rate not only among physicians, but other professionals as well, those in education, those in mental health services, those in service-oriented careers, tend to burn out at a higher rate than the average population. So this is a very huge challenge among physicians, particularly in the last little while. As we continue to talk about the personal mental health of doctors, I want to share some details with you that really reinforce the issue that we have that's facing physicians today and any medical professional. Every year in the United States, roughly 300 to 400 physicians die by suicide. And that translates in the United States that suicide rates are extremely high among the profession, the medical profession. In the U.S., suicide deaths are 250 to 400% higher among female physicians when compared to females in other professions. So with that data itself, we know that there is a huge amount of pressure on those who are in the medical field. I talked to one physician who told me that it was not just, the stress was also about seeing people die and working with people in terminal situations or tragedies or shootings or whatever, the most horrible things you can think of. But it was also, how do we report that and then be questioned about the report that we just gave by a government agency or by local government to say, well, wait a minute, did you really see all that many people die, or did you have? And so the stress of reporting this was also a causative factor for depression and burnout among the doctors that I've talked to. In the general population, males complete suicide 4 times more often than females. However, female physicians have a rate equal to male physicians. So medical students also have rates of depression that are 15 to 30% higher than the general population. Now, I'm really not just giving you this as statistics, just as filler. I want you to think about this. This is from the American Foundation for Suicide Prevention. Medical students, so they're already starting their career. They're starting their profession with the predisposition to suffer from depression. It's a major risk factor in physician suicide. Other factors include bipolar disorders and alcohol and substance abuse. Women physicians have a higher rate of major depression than age-matched women with doctorate degrees. You would think that maybe with a doctorate degree or with higher education, there's more knowledge about how to deal with stress and with the exigencies of life. But when you factor in the reality of this and you look at it, we find that often the higher the education, the higher the opportunity, the higher the career opportunity, the higher the income, the more there's a likelihood of there being major depression or anxiety involved in those populations. We find that contributing to the higher suicide rate among physicians is their higher completion to attempt ratio. And that may result from greater knowledge of the lethality of drugs and easy access to means. Often we talk about gun violence in America, and truly it is an issue that needs to be faced. But what about those who have access to drugs and know what drugs to use? Someone shared with me, a medical professional shared with me one time, they said, you know what the number one drug problem in America is today? And I was like, probably cocaine or fentanyl. Or he's like, no. He said, it's prescription drugs. We have so many people who keep and hoard their prescription drugs that they tend to abuse it. They self-medicate, or a child or an underage person gets in there and finds the pharmaceutical stash, and they end up dying as a result of an overdose. So we have a serious issue, and so just to emphasize the fact that one of the reasons that rate of completion is higher than the attempt is because there is a knowledge of the lethality of those drugs and easy access to it as well. According to the Medscape Physician Burnout and Depression Report in 2022, 43% of the respondents, talking about medical professionals, indicated that they did not seek care for depression or burnout because they did not want to risk disclosure to their medical boards. Now think about this for a minute before we go further. I just want to pause for a second and let's talk about this a little bit. So the medical board, obviously the medical board is important. The medical board has a responsibility to watch over the professional activities of its members. But think about that for a moment. I think because there's a lack of clarity about what medical boards are looking for and what they would do with that information, that means that everything gets shut down. I don't think any legitimate medical board is going to say, we expect all of our physicians not to have any issues with anxiety or depression or burnout or whatever, or grief or loss or whatever may be going on. That's part of the human life. That's part of the human existence. And so I think there's a feeling among the respondents that medical boards should not know anything about what's happening. And therefore, I'm not going to talk about it. I'm not going to get treatment for it. I'm not going to get any medication. I'm not going to do anything for depression or burnout because I don't want to risk my career. Startling 32% said they didn't want evidence of treatment with their insurance providers. So why do we have HIPAA? And why do we have all of these emphases of confidentiality? Another 63% of physicians reported experiencing at least one symptom of burnout since the pandemic. And this was a serious symptom. It wasn't just like, oh yeah, today I just, wish I could, go to work at Walmart. It was a situation where it was like, you know what? I seriously want to quit my job. 63% since the pandemic. And so I think depending on the location, I think depending on the particular practice, I think depending on the population that they serve, that number could go up or down as a result of that. So while difficult to address head on, there are strategies that can help reduce stigma. And I really want us to think about this for a little bit. How can you as a professional reduce the stigma related to maybe your own treatment with mental health issues? And how can you help reduce the stigma that's associated with treating your clients and your patients? So we're talking specifically about stigma that may be present with a primary care team. So let's look at these three areas. Number one, uncovering unconscious bias. All of us have a level of bias. And whether that has to do with cultural or ethnicity biases, or if it has to do with our biased perspectives about mental health, we need to address false beliefs that may exist. Now, sometimes within the care team, the community, and the culture, there are false beliefs. For instance, one is anybody who experiences mental health issue is crazy. I always do this little test, a little pre-test I do with my counseling students. I say, okay, tell me the first word that comes to mind when I say mental health. And they're like, crazy, bipolar, all these other things that go with it. And I'm like, you know what? Mental health should be a positive thing. Your mental health is important. Your mental health should be a priority. We don't feel that way when we talk about physical health. If we talk about your physical health, if you say that phrase, physical health, people don't immediately think that you're diseased. So what is it about this? We're always down on what we're not up on. It's because we don't understand mental health. We don't understand what that entails and what that means. And I think that helps form our bias. It's also what we listen to with others. False beliefs that may exist within the care team, the community, and the culture. Cultures often have a different approach. You will have, in certain cultures, a belief that you don't tell others what's going on with you. You keep all of that in the family. You have cultures who believe that if you show any kind of, or you talk about any kind of mental illness or having a mental health challenge, that means that in some way, some form, you are weak, are not capable of doing what you need to do. So we need to uncover the unconscious bias. We need to have some real heart-to-heart talks with our team. It would be great to bring somebody like myself in and sit down with your care team and say, let's talk about mental health. Let's hear it from the professionals. What is it? What does it mean? What does it not mean? What are the false assumptions about mental health? And what is the reality? And let's talk about it from there. I think another thing that would help in terms of addressing stigma is let patients be the educators. I think there's a tendency for us to always be in the diagnostic mode, where we're looking to say, well, this sounds like this. I think this is what, not everyone can be fitted neatly into a diagnostic code. I tell my students who are becoming licensed professional counselors, not everyone fits into the DSM-5. It just doesn't always work that way. So be careful that we don't tend to be more of a judgmental, biased, have that judgmental bias approach by diagnosing rather than listening. We need to create space for our patients, for our clients, for the team, for everyone to listen as these people present their behavioral health challenges and find ways to connect with them. It's okay that you've been depressed. It's okay that you've suffered from PTSD. It's okay that you've had mental illness. This is what faces us as a world, as a population. I think the third thing that we could do to really indicate that we're serious about minimizing stigma is by showing that recovery is possible. We need to empower the team to be part of the solution, highlighting how recovery can happen. We shouldn't approach a situation by saying, well, that's the way it is, it's never going to change. We're just going to treat the symptoms. No, there's a way that we can treat the root causes. We can find ways. We can move toward various levels of recovery. So uncovering unconscious bias, letting patients be the educators, and showing that recovery is possible. In doing this, we tackle this stigma issue head on, and we begin to look for the day when the stigma of mental health is significantly and hopefully permanently reduced or eliminated. So let me talk to you a little bit about basic practices for practitioners. So how do we work with people who come in presenting a mental health issue? Well, let me give you 5 things. 5 basic practices for practitioners. First of all, take time to listen. Now we kind of alluded to that earlier. But what do I mean when I say listen? Listen is a two-way street. Just because I'm hearing something doesn't mean that I'm listening. My favorite analogy of that is the husband who sits in front of the television and watches flips the channels while his wife is trying to talk to him about the stresses of the day, and he's like, yeah. Well, he hears her, but he's not listening to her. It's when he puts the remote down, disengages from the television, and makes himself available to listen to her. I would say, as a physician, clients, patients of yours feel very good when you're able to come in, set the laptop aside or the iPad aside or the notepad or whatever you're using, and just stop for a moment and listen. Talk to me. Tell me what's going on. No note writing, no engagement, looking at the person, engaging them verbally, listening, watching, looking for cues, totally engaged with this client or this patient. Number one, you listen for subtle underlying messages. What are they saying? They may not just come out and say, I have depression, but if they start talking about, I'm just feeling really blue, I don't enjoy the things that I once did, those kinds of things, that's an underlying message. Listen for incongruent speech. How are you doing today? Oh, I'm great, I'm good. And then the way they say it is not necessarily how they're presenting with their body language. That's what I don't like about text messages and using the technology that we have, is because it's so two-dimensional. It's one thing to say, hey, how are you? I'm fine. If I say I'm fine, or I say, oh, I'm fine. Two different ways. It's incongruent if I say I'm fine and I don't have the body language to go along with that. Listen for stress and stressors. What are the real issues at stake? What are those things that are producing the stress? And listen before making a diagnosis. There are so many diagnoses that are so close. And if we don't listen and take the time to listen, it's easy to misdiagnose because we didn't hear all of the rest of the story. We didn't hear the rest of the issues or the factors that are being presented. And number 5, under this listening situation, listen and then paraphrase to make sure you heard what's being said. Remember when I said earlier that communication is a two-way street? Listening. And then when you hear them say this, or you listen to it, then you say, okay, let me make sure I heard you correctly. You just told me that A, B, C. And at that point, the person can say, that's exactly right. That's what I'm dealing with, A, B, C. Or the person would say, no, I really only said A and C. I didn't say anything about B. So listening and paraphrasing, making sure that what you are hearing or what you're listening for is what that client, that patient is trying to communicate. So listen and then paraphrase. Now, this may have to happen 3 or 4 times before you get it accurate from them, because this may be the first time that patient has ever articulated what he or she is trying to discuss, particularly as it relates to their mental health. Now, another thing, take notes that encompass the biopsychosocial aspects of the client. Not just there to look about the physiological, that's important. We've got to know heart rate, heart beat, breathing rates, all that kind of stuff. You got to listen, you got to use the stethoscope, you got to find out oxygen intake, all that kind of stuff, but also what's going on in that client's life. What's happening with that patient? What's happening around that patient is very, very important. Thirdly, always make sure to refer clients who need psychotropic medications to appropriate mental health professionals. For example, licensed professional counselors or psychologists or social workers or whomever it may be. If you are going to prescribe a psychotropic medication, please let me encourage you to follow up with that client and make sure that a mental health professional is following up with that client, with that patient, because you may not see them for another 3 months or 6 months. But that counselor might see them once a week for the next several weeks. And that's where release of information can be signed, where everyone can be talking. The medical doctor can be talking to the mental health professional. The client can be talking to both of them to find out what's going on, how this is working, what they're seeing, and that will give you an opportunity to adjust medication or discontinue it or whatever it may be. But I would say always make sure that your clients have options in terms of, don't just say you need to see a counselor. Give them a name of a counselor. Help them set up an appointment with a counselor as if you would a specialist that you are referring them to. And number 4, advocate for mental health and seek to reduce the stigma that's often associated with mental health and mental illness. You can't imagine how difficult it is for people who, one, may have never talked about this subject in their life, but they feel comfortable enough with you to be able to say, this is what's happening in my life. These are the things that I'm concerned about. But also, you may have people who have had experience with mental illness before, and they're afraid to talk to you about it because they kind of see the things that happened in the past. It may be coming back, some of the same stuff, and they're a little afraid. So make an environment where your patients feel comfortable talking to you, and that will reduce the stigma that's associated with mental health and mental illness. And number 5, and finally, take advantage of professional development related to mental health. Any opportunity you have to get some training for medical professionals that is being put on by someone who could talk about diagnoses or talk about working with a particular situation like with depression or people who've gone through grief and loss. Any kind of special professional development like that can only make your practice better, more informed, and more relatable to your patients. So with that, and after we've covered all of this, here are some conclusions that I want you to take away with you. Number 1, remind yourself that physicians are real people too. You are real. You don't have to hold yourself to a higher standard than you hold everyone else. 2, remember the patient is a tripartite entity, a body, a mind, and a spirit. And yes, many, if not most, of your clients are indeed connected with spirituality. So remember that it's not like Freud, who just says they're just a body and a brain. They have a spiritual essence to them as well. Thirdly, schedule time with a mental health professional as you would schedule with any other healthcare professional. You have to go to a dentist on a certain every so often, or you should. You have to have your own medical checkup every so often, or you should. Why not have a mental health checkup, a mental wellness checkup? There's nothing wrong with that. To have a counselor or a life coach to help you as you move through. You've got a lot on your shoulders, and it's great to have. I tell my students, every counselor needs a counselor. And if I say that to the mental health professionals, I say that to all other healthcare professionals. If you are a healthcare professional, you do need someone that you can talk to. Fourthly, explore training to enhance your ability to spot mental health concerns in your patients and yourself. In other words, be strategic about the training that you want to receive. There are things that are happening in your clients' lives. There are things that are happening with your clients, and you see this. You see a lot coming in, maybe with anxiety or depression, and you're like, man, I need to really be as equipped as I possibly can be to address these concerns. So watch for that training and look for it to enhance your ability to be strategic. And then I want to say it in a different way. It's okay to be human. Remember I said the very first one, remind yourself that physicians are real people too. But here I want to say it's okay to be human. You're going to make mistakes. You're going to find yourself feeling bad, feeling not so great about a day or about a situation or an event. It's okay to be human. Be gracious to yourself. We couldn't make it without our amazing medical professionals. There's no way we could do it. But we want you to take care of yourself along the way. Well, I want to thank you for the opportunity to share with you, I think, some of these points that will help you as a professional and will help you as you connect this medical well-being with mental health. I hope if you have questions or comments about this, you'll reach out and let me hear from you. Thank you so much. Thank you for all that you do for those who need you so much.